And hello, everybody. My name is Thomas Sathe-Bazette. I am the Director of Operations and Health Policy of AdMeTech Foundation. I would like to welcome you all to our annual prostate cancer awareness event with the Cambridge NAACP. Where I just want to start off by saying how grateful we are for this partnership and this annual event that has been going on for now about 3 to 4 years. This is an important event, and we're always appreciative partnerships that we have with the branch. And I'm going to turn it over to the president of the Cambridge NAACP, Mr. Ken Reeves. And Ken, the floor is yours.
Okay, thank you, Thomas, and thank you, Dr. Stern. And the Cambridge branch NAACP, the National Association for the Advancement of Colored People, is a civil rights organization, and we are 114 years old. And we attempt to address inequities that continue in our society. We are an organization that would love to go out of business, but we seem to get more business as the years go forward. The business of inequity today that we are going to discuss is that of prostate cancer, and particularly as it is inequitably visiting men of color, and particularly Black men. And the Cambridge branch has chosen to steep itself in this issue at the invitation at the AdMeTech Foundation, but I must make it known that in Cambridge, now nearly 30 years ago, we started a Men of Color Health Task Force to look at the health of men of color and healthcare disparities that were in our city, and we quickly came to prostate cancer as one of our principal concerns. So we're glad to have the partnership with AdMeTech about this issue. Now, as I mentioned, I'm the president, but I'm also a patient with the problem. I was diagnosed with prostate cancer approximately 6 years ago. And after that diagnosis, I became quite a reader of whatever is on the internet about prostate cancer, and began to read some books that were about it just so I could best understand. I was diagnosed with stage 3. So earlier stages, sometimes people get to do what they call watch and wait. I wasn't in that group, so I had to make a choice of what my treatment mode would be. And I happened to choose something called CyberKnife, which is a relatively new technology that you have approximately 6 treatments and some follow-up with hormones, and that is supposed to do the trick on early onset prostate cancer. In my case, I was great after the first year, but subsequently my numbers kept going up and up and up, and couldn't figure out what was why. And I happened to talk to our then regional director, Juan Cofield, and as I was talking, he said, I need to connect you to Dr. Stern and AdMeTech, because it sounds like you're somewhat lost as to where you might be in the journey. And, I attend church because I know I need the prayer. It's not because I'm so good, but I do think this has been an answered prayer, because upon meeting Dr. Stern, she was able to help me to get to a particular service that was not available in Massachusetts. And so I had to go to Sloan Kettering in New York, and she was able to arrange and make that possible. And when I say she was able to arrange and make it possible, I mean that the application process to get the test in New York was so cumbersome and so time consuming and so nerve wracking that we would send things and they would lose them and we would send them again. And then we'd find out that when we think everything was in, they'd send back and say, well, you know, this particular thing you sent 31 days ago, so you have to send it all over again. But Dr. Stern stepped in and made things right. She turned the ship upside down until it could float on it with good sails. So I I could not be more of a fan of this program. I think all and anybody getting involved in this cancer system, I call it, needs help with navigation, but men of color particularly need it. I mean, I'm a Harvard grad. I have taught at MIT. I have a number of things that would make you think I could get through any quagmire. Well, the cancer system is a quagmire that you could really use experienced physicians help to guide you through, to explain, to hold your hand, whatever way the cancer enters your story. AdMeTech is there to help guide particularly men of color, and I think Black and Latino men are well aided by it. And I want to say that our state legislature and our governor must better understand of the particular importance of this program because there is nothing else like it. And I know that Dr. Stern we've made referrals from Cambridge to the program, and we have some participants who are just couldn't sing its praises more, not because it's propaganda, but because it's helping their lives intimately and daily. And I think that is a testimony to the quality of both the leadership and who can be put in the circle. So I will end there. I will say this last thing. It's pretty clear that everybody's cancer journey is different, very individual. And the thing I like about AdMeTech's help is that it's really tailored to you and your concerns, catching you where you are and taking you forward from there to the next step in a very personal way, which is something I really like. And I'm so happy for my Black and Latino former constituents who can take advantage of this because I know that they're in great hands, and we check back with them, and they can tell us that they're quite satisfied with how things go. And last, the follow-up here. Dr. Stern, I know, is in touch with several of the people beyond their medical procedures, just checking in with them to see how they're doing. That means so much to them, and it means so much to me. In my elected life, I didn't like to just refer people. I like to help to see them get to where they were going and see where they landed. And I'm so glad to know that I put several people in good hands, and they're landing very well. So thank you, Thomas. I appreciate the Cambridge branch. Appreciate you. Our first Vice President, Richard Harding, can't be with us, but we do have our secretary and acting treasurer, Aisha Wilson, who is really keeps us all connected. So I want to say a shout out to her.
And before, there is one correction I want to make. Along with Aisha working with us on the NAACP side, I just want to mention that she's an elected official, Cambridge City Councilor. So I do want to correct that error that I made earlier. So I do appreciate her role, not only with that, but also on the city level as well. So we really appreciate it, Aisha, for all the hard work that you do to help us.
I just want to, first of all, thank President Reeves for his kind remarks. But I want to refocus a couple of things. Talking about civil rights issue, when I saw that Black men are dying at the rate of 2.5 times higher from prostate cancer compared to white men. Of course, it was obviously not just health disparity, it was one of the leading health disparities. For any person, definitely a leading health disparity for men, right there with diabetes and maternal health and infant mortality, some of the most recognized disparities, except for prostate cancer, is very rarely isn't on that list publicly. So first of all, I was shocked when I was embarking on my career in prostate cancer. I was shocked by the disconnect between the numbers and the public knowledge, public awareness. I was coming from a breast cancer community, so of course awareness was very important in breast cancer. And my second reaction was there was no biological or clinical reason for Black men to die so much more commonly. For me, it was fundamentally a civil rights issue. So we really appreciate partnership with NAACP, which is a civil rights organization, because there is no question on my mind. There is no question. And then I started talking to world authorities in health disparities, and they agreed with me. It was beyond any kind of disparity. This is a the fundamental civil rights issue. I also want to say that although we've been a lot for many, many years in large-scale public awareness programs, more recently we established a prostate cancer equity program because we want to help men not only through the group or individual education, we want to help in their journey, in their clinical journey. We want to make sure they have access to the best care available. When Mr. Reeves came to me, a little bit lost in his journey, the first thing I asked him was, "Are you comfortable with your care?" And he said, "I'm not." And I asked him, "What was the reason for your discomfort?" He said, "Nobody's in a driving seat. I am going from one doctor to another doctor. They're telling me different stories, but I do not have experience that anyone actually is in a driving seat of my patient care, that I'm in the driving seat of my patient care, and I should not be there." And he was absolutely right. And third thing that struck me was that he did not get access to the exactly diagnostic tool, sort of what was suspected clinically because his numbers were off, that his cancer came back, but nobody knew where this cancer was. And the very advanced imaging tool that could have made this diagnosis and ultimately did was not made available to him. And so basically this is, so we immediately fixed two things. One, we connected him with the doctor who put himself in the driving seat. He just had second nature for this particular doctor. And that's the kind of doctors we choose for our prostate cancer equity program. And secondly, we made sure, although at that time it was not a regular clinical tool, it was experimental tool available only at Memorial Sloan Kettering. And if you essentially Northeast, Memorial Sloan Kettering was the only place in 2021 when this diagnostic tool was available. So although it was clinical trial, it was bureaucracy, we gave him access to the diagnostic tool without which clinical decisions could not be made. So we are grateful to you for trusting us, President Reeves. And we are so pleased to see how your physicians this day are definitely putting themselves in the driving care and take full responsibility for the quality of care you're getting at Dana-Farber.
Thank you, Dr. Stern. Our next speaker, while he is not able to attend, did provide a video of his presentation. Dr. Sean Wason is a faculty member, Division of Urology and Associated Physicians, Harvard Medical Faculty Physicians, Milton Center for Specialty Care, Needham Urology Associates, Beth Israel Deaconess Medical Center, Beth Israel Lahey Harvard Medical School. Dr. Wason will review advances in the patient care with a focus on screening and diagnosis. Emma, if you can play the video.
My name is Sean Wason, and I'm a faculty member in the Division of Urology at Beth Israel Deaconess Medical Center. I primarily work out of Milton and Needham hospitals, and I'm a part-time lecturer at Harvard Medical School. I was asked to give a talk on advances in the screening and diagnosis of prostate cancer. I have no disclosures related to this talk. We all may know someone that's been affected by prostate cancer. For me, it was my grandfather, Ernest Wason, who grew up in the sunny island of Barbados, the easternmost Caribbean island. I dedicate this talk to him. The objectives of my talk are to review the goals of screening. Who do we screen? When do we screen? How do we make the diagnosis? And how are we using imaging and biomarkers to screen our patients? Typical patient that may present to me in my office for prostate cancer screening. He's a middle-aged male. He has a strong family history of prostate cancer. Notably, his grandfather died of metastatic prostate cancer, and he has a brother who was recently diagnosed with localized prostate cancer and is undergoing treatment. He has no significant voiding symptoms. He feels well. He works out frequently. He does have well-controlled hypertension, and he takes medications for this and a statin for his elevated cholesterol. He drinks alcohol occasionally. He doesn't smoke. He's married, and his erections are normal. He was noted to have a relatively normal digital rectal exam that was round, smooth, slightly enlarged, but his PSA was 4.5 nanograms per milliliter. I like to review the prostate anatomy with patients. The prostate is typically the size of a walnut, measures about 30 grams, and is part of the urethral channel. It's tucked in between the bladder and the rectum, and the backside of the prostate can be palpated by performing a digital rectal exam. The function is a reproductive organ, and it contributes to semen. What we do know is that prostate cancer is common. It affects 1 in 8 men in the United States. If detected early, the 5-year survival rate is nearly 100%. The goals with prostate cancer screening are to minimize the detection of non-life-threatening cancers and maximize the detection of intermediate and high-grade cancers, as well as decrease the unneeded biopsies and treatment. As established by the American Urologic Association on the early detection of prostate cancer. What we mean by early detection is screening, and both imply detection of a disease at an early pre-symptomatic stage when a man would have no other reason to seek medical care. The panel recommends against PSA screening in men less than the age of 40. In this age group, there is a low prevalence of clinically detectable prostate cancer. The panel also does not recommend routine screening in men over the age of 70, unless they are in excellent health and they may benefit from screening. The panel strongly recommends shared decision-making for men in between the ages of 55 and 69 with either their primary care physician or urologist, and then proceeding with screening based on a man's values and preferences. How do we find prostate cancer? The 2 most common ways are a blood test measuring PSA or prostate-specific antigen, as well as a digital rectal exam. Screening is best performed when these 2 are taken in combination. Typically, PSA and digital rectal exam are done annually for screening, but this does not tell you if someone has prostate cancer. You need a prostate biopsy in order to make the diagnosis. PSA stands for prostatic-specific antigen. It's a protein in the semen that liquefies the ejaculate. It circulates in the blood of all men with intact prostates. The good news is PSA is only made by the prostate. However, prostate levels can be elevated for several reasons, such as inflammation, trauma, or natural enlargement as men age. I think a lot of men need to know, what is your PSA and what is the trend? What is the velocity? How quickly is it rising? One of the earliest known biomarkers used in urology. It's used in several phases of the disease, including screening, diagnosis, after local treatment, in advanced as well as metastatic disease. In regards to PSA screening, from a urologist's perspective, most would agree that mass screening is in the past. PSA does have several limitations. It's not a definitive test for prostate cancer. Shared decision-making is important. High-risk patients, such as those with first-degree relatives and family members, should be considered for screening. Age and comorbidities will often dictate who gets screened, which is also dictated by primary care providers. Who gets biopsied and diagnosed is often dictated by urologists. The National Comprehensive Cancer Center also has their guidelines on the early detection of prostate cancer. If a PSA is less than 1 nanogram per milliliter and there is a normal digital rectal exam, repeat testing can occur at longer intervals. If a PSA is in between 1 and 3 with a normal digital rectal exam, repeat testing should occur at 1 to 2 year intervals. If a PSA is greater than 3 or there's a suspicious nodule on digital rectal exam, the PSA should be repeated and this patient referred for possible biopsy. In these patients, we would consider the use of multiparametric MRI as well as biomarkers. If there remains a high suspicion for prostate cancer, these patients should undergo prostate needle biopsy. If there's a low suspicion for prostate cancer, the PSA and digital rectal exam can be repeated at a shorter interval. In my practice, I often use transabdominal ultrasounds to determine the size of the patient's prostate. By taking the PSA divided by the prostate size, we can determine the PSA density. The denser the prostate is, the more concern there is for prostate cancer. Biomarkers available for risk stratification in patients with suspected or known prostate cancer. Biomarkers are biologic molecules typically found in blood, urine, or tissue that can be used as a marker of normal or abnormal processes within the body. Biomarkers can be used in all aspects of patient care. It can be done for a biopsy, prior to repeat prostate biopsy, after biopsy, or post-treatment. Biomarkers should, however, not be routinely used in all patients. We use SelectMDx, which is a urine-based biomarker in my practice. I will use this for patients that have had a negative prostate biopsy in the past. Those patients with a very large prostate with a smaller concern for prostate cancer, and those patients that may be in the gray zone or hesitant to proceed with prostate biopsy. The assay looks for 2 genes, HOXC6 and DLX1, that have been shown to be associated with prostate cancer. Findings associated with the digital rectal exam, the PSA, the patient's age, and the prostate size are combined into a report that tells us the likelihood of finding prostate cancer upon biopsy, as well as, more importantly, the likelihood of detecting a clinically significant prostate cancer, which is considered a Gleason 7 or greater. I will also typically use multiparametric MRI frequently in my practice. In patients considering a prostate biopsy, all patients will undergo a multiparametric MRI, which stands for magnetic resonance imaging. There are several sequences performed in the MRI, and we can evaluate the MRI for suspicious areas within the prostate if there is evidence of extracapsular extension, seminal vesicle involvement, lymph node involvement, or possible bony metastasis. The radiologist will give us a score, PI-RADS score, from 1 to 5. And I think it's extremely important for men to know, what does my MRI show? Does it show any PI-RADS 4 or 5 lesions? And where are the lesions? Another imaging modality that is currently being employed is microultrasound. This is a high-resolution ultrasound probe that provides real-time images similar to a standard transrectal ultrasound. This can be used in both the initial biopsy phase and the surveillance phase on patients diagnosed with prostate cancer. The images provided by microultrasound are far superior and can provide detailed local anatomy. It also has a very similar scoring system to the PI-RADS system called Primus. The higher the number on the Primus score, the higher likelihood of finding clinically significant prostate cancer. Prostate biopsy is typically performed transrectally, and the goal is to sample the peripheral zone of the prostate. On average, 12 cores are taken, 6 on either side, in the peripheral zone of the prostate. The prostate biopsy will tell us, is there prostate cancer or not? What is the Gleason grade, which is the aggressiveness of the prostate cancer? Gleason 6 prostate cancers are the least aggressive, whereas Gleason 10 prostate cancers are the most aggressive. The prostate biopsy also estimates the volume of the cancer, the number of cores involved, what is the location, and if there is perineural invasion, which is a poor prognostic indicator. There are 2 standard ways to perform a prostate biopsy. One is via the transperineal, and the other is via the transrectal route. Both are typically performed in the office under ultrasound guidance by a urologist. The added benefit of performing the transperineal biopsy is that anterior aspect of the prostate is more easily sampled. There may also be a slight decrease in the risk of infection via the transperineal route, although recent data is questioning this. Multiparametric MRI ultrasound fusion is a technique used to sample lesions noted on MRI. After the MRI is complete, the radiologist will encircle the lesion on the MRI, and then these images can be fused in real time to a standard transrectal or perineal ultrasound to ensure that the lesions that are noted on MRI are sampled. As prostate cancer can be found 15 to 20% of the time in other areas of the prostate without a lesion, usually the fusion-guided biopsy are also performed with the standard 12-core needle biopsy. After the prostate is sampled, the cores are all sent to a pathologist for evaluation and are given a Gleason grade, which ranges from 6 to 10, 10 being more aggressive. Patient needs to know, what is my current Gleason score? Once we know the Gleason score, the number of cores involved, the PSA, the digital rectal exam finding, the patients are given a risk category ranging from very low, low, intermediate, high, and very high risk. This will determine the extent at which imaging studies need to be performed for evaluation of disease outside of the prostate. In patients with low and favorable intermediate risk disease, genomic biomarkers can be performed on tissue removed at the time of biopsy. This will determine the biologic aggressiveness of the prostate cancer. This is useful for patients considering active surveillance. In patients found to have unfavorable intermediate risk, high risk, and very high risk disease should undergo additional imaging to ensure that there's no metastatic disease or disease outside of the prostate. Traditional imaging includes CT scan of the abdomen and pelvis, as well as a bone scan. Although CT and bone scan are still widely being used for imaging, slowly this is being supplanted by a more sensitive test called PSMA PET scan. PSMA stands for prostate-specific membrane antigen. This is a protein found on the surface of most prostate cancer cells. A radio-labeled pharmaceutical agent is tagged to PSMA. The whole body is scanned, and this will easily identify areas outside of the prostate where there may be prostate cancer metastasis. After a diagnosis of prostate cancer, many men will ask, how can I be proactive in my fight against prostate cancer? One of the fathers of prostate cancer treatment is Professor Laurie Klotz from the University of Toronto. He recommends smoking cessation, consider a low-dose statin, vitamin D supplementation, as well as metformin. In summary, prostate cancer is common and its aggressiveness is quite variable. Earlier detection is favorable and can lead to a cure a lot of the time. Our goal with prostate cancer screening is to maximize detection of intermediate, high, and lethal cancers, minimize the detection of non-life-threatening cancers. We can do this with improved imaging and genomics, which can improve risk stratification. This has also allowed urologists and patients to be more comfortable with active surveillance. Thank you for your attention.
Thank you to Dr. Wason. We've always appreciated his support over the years for submitting these videos and even presenting in person for this and answering questions. And we've always been very grateful to Dr. Wason. Next, want to introduce Dr. Stern, President and CEO of AdMeTech Foundation. Dr. Stern, the floor is yours.
Thank you so much. Once again, I would like to join Thomas in expressing my gratitude to Cambridge NAACP for your partnership. I believe it is our third annual prostate cancer awareness event. Thank you for a continuous partnership. And without further ado, perhaps Emma can initiate my presentation. We put my presentation on a video to make sure to avoid any technical problems. My name is Faina Stern. I am grateful to Cambridge NAACP for a great partnership in creating the third joint annual prostate cancer awareness event. AdMeTech Foundation is a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. Dr. Sean Wason described recent advances in patient care. The main topic of my presentation is our prostate cancer equity program and its mission to bring these cutting-edge advances in screening, diagnosis, and treatment to Massachusetts men and eliminate health disparities. Prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education and research, and clinical care equity. We are grateful to the members of the Cambridge delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2013 in collaboration with multiple organizations and has 4 components: public awareness, community education, prostate cancer equity and clinical care, medical education, and research. Our public awareness campaign, community education and outreach, is focused on the most vulnerable and underserved individuals. Since January 2023, we reached over 15,000 underprivileged individuals. This is a 50% increase compared to what we reported last year. Since 2019, our public awareness and education program reached over 52,000 people. For public awareness and education, our messaging is centered on the importance of screening and early detection critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. The center of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 7th annual conference took place in September last year. Our summit has been recognized as a seminal event in shaping the state of the art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. Last September, we had over 300 physicians participating during this event. After the event, our media partners published over 60 scientific presentations and reached over 35,000 physicians across the globe. It's difficult to find any corner of the world that has not been reached by this event. Our summit showed that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men.
It is particularly important now, with so many novel diagnostics and therapeutic approaches, ensuring high quality, personalized, precision patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care to all. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We strongly believe that our prostate cancer equity program, integrated with our large-scale public awareness campaign, has been placing Massachusetts in a strong position to become the first state in our country to eliminate health disparities. Experts on the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of their families and friends. This process consists of three components. One, AdMeTech Foundation's team members collect basic information and match individual patients' needs with the appropriate state's experts for clinical care. Two, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, any insurance, and financial assistance if needed. Three, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. I'd like to share with you a few recent examples of how Prostate Cancer Equity Program has been making a difference. This is a case of a Black man with a history of prostate cancer who is currently being treated. On May 15, his doctor informed him that his scheduled treatment could not be provided due to problems with the insurance coverage. He got upset and shared his situation with Representative Beth Williams and a leader of the Men of Color Health Awareness Program, MOCA, our community partner in Springfield, who referred him to us. On the late afternoon of May 26, right before the Memorial Weekend, he contacted us and appealed for help. Our primary goal was to restore his treatment as soon as possible, and we immediately reached out to Dr. Mitchell Sokolov and his team at UMass and secured their support. On May 30th, right after Memorial Day, UMass Urology provided guidance to this man how to address his insurance. By Friday the same week, on June 2nd, the insurance issue has been resolved, And the appointment with Dr. Sokolov was scheduled at the earliest opportunity in early July to resume his treatment. The following Monday, on June 5, a local leader heard about what happened and asked for a second opinion for his own urologic health issue, and received an appointment with a leading urologic expert within a few days of his request. This is a story of a Black man in his mid-50s who was referred to us in mid-May by Cambridge NAACP. This man was recently diagnosed with prostate cancer. He got alarmed when his urologist informed him that the best care will not be available to him due to his limited insurance. We connected him right away with the patient navigator at the Mass General Brigham. She obtained a referral from his primary care physician and secured approval from his insurance. 3 weeks later, by June 6, this man saw Dr. Adam Feldman, a leading clinical expert and one of our featured physicians. Dr. Feldman described various treatment options, but recommended curative surgery, which was performed in mid-August. We asked a few men to share how prostate cancer equity program has been making a difference for them. The first video was provided by Jose Javier of Lawrence, Massachusetts.
Hello, everyone. My name is Jose Javier. First, let me begin by thanking Dr. Stern for inviting me here today and being part of this. I'm excited to share with you and grateful to be able to share with you for a few minutes a little bit about my story and my experience with AdMeTech in the organization. I met Dr. Stern around the fall of 2015. I heard about her from a friend of mine at church, Victor McCann, which I'm grateful for, because he was going through the same thing, and he was able to share at church, and I heard his testimony, and I was able to approach him after the service, and we had a great conversation. I was very shy about this subject. I, too, had a very high count on my PSA exam and had to go in for a biopsy. And I learned from Victor McCain the difference between an MRI biopsy, a guided biopsy, and also what is referred to as a blind biopsy. And those made a difference in my life. And I was able to meet Dr. Stern through this process. And I was able to go and get a MRI guided biopsy at the NIH and so forth. And it was a fantastic experience for me. So for me, part of the takeaway when it comes to this is really to be aware. Be aware, learn about the processes, learn what's available out there, what programs are available for you, what are the best tools to do the job. A very important thing is to share it. That's what I learned from my friend Victor, is to share it at church, share it with other people so they can learn as well. And because in our community, especially in the Black American community and the Latino community, it's a subject that is not often spoke about. When we talk about our private parts and speaking about the prostate, it's not always a conversation that is too welcoming in our community. So I would encourage people to share it, to learn. And as Governor Baker always says, get tested. It's easy to get tested. Ask your doctor for a test. And be aware and that there are solutions out there. We have great referrals, we have great doctors, and contact the leadership, the people at AdMeTech, and they're able to guide you in the right direction. Thank you. Please allow me to say a few words in Spanish. Para nuestra comunidad en español, este tema de cáncer en la próstata es un tema súper serio, muy serio. Y es un tema que nos impacta a nuestra comunidad significantemente. Yo le quería decir a ustedes que, por favor, hablen con su médico. Si sienten algún síntoma, si están teniendo problemas orinando, cualquier irregularidades, hablen con su médico. No tengan miedo de conversar con su médico. Hablen con personas que tienen experiencias similares y eso le puede salvar su vida. Lo más importante es hacerse un examen PSA. Por favor, estudienlo bien y aprendan más. Gracias.
The second video features Ronald Roberts, who was referred to us by Martha's Vineyard NAACP.
Hi, everyone. I'm so glad to be here. My name is Ronald Roberts, and I'm just so glad to be included in this presentation. I have known about AdMeTech, and I met Dr. Stern years ago, and I would have never thought that I would be needing them so much last August when I was diagnosed on July 4th with prostate cancer that had spread to about 3 organs and lymph nodes, and I was in really bad shape. I ended up talking to Dr. Stern later on, and she directed me in the right direction. I ended up at Dana-Farber and jumping around to Brigham and Women's. I'm just fortunate, I consider myself fortunate to live in Massachusetts, where the medical help is available. If you know where to go, it really paid off for me. I'm doing pretty well after going through the MRIs and using the advanced equipment was provided to me. But through the direction of AdMeTech, I got to the right places. It takes a lot of willpower and positive thinking to do and go through what I did. I ended up driving over 3,600 miles, and that was after I had a driver that used to take me when I was weak. When you add the radiation, chemo in, 34 more appointments, it comes out to a lot of appointments, and I made every one. It was nice to know there was always somebody in the background that could help out if I had I needed an opinion, and that was AdMeTech. And to bring people like myself that are patients, been exposed to the cancer, and survivors and people from the medical field and politicians. It's something that's badly needed for the minority community. We have the knowledge there. Things have changed a lot in terms of prostate cancer for the better. I'm taking a drug that's only 3 years old that has excellent results, but you got to know where it is and you got to be guided in the right direction. It's kind of frustrating that there's so many people out there that do have it and are not getting the help or not getting the proper help. I had put it off for years. I knew back in 2010 when I had Lyme disease, relapsing polychondritis, and babesiosis, and I forgot what else, all at the same time. I tried to treat the cancer back then with chemo, and it just got worse. So I just put it on the back burner. And I didn't even feel anything up until the few months before I was diagnosed, and that was I couldn't hold food down too well. Fortunately, a lot has changed since 2010, 11 when I was treated. There's a lot out there, a lot of new advanced machinery that can help with MRIs and radiation. We're fortunate in Massachusetts to have it available, and especially the Boston area. Without AdMeTech to guide you and be a resource, it's just so crucial if you need it, because sometimes you got to make a decision as to what the treatment is, and everybody's different. The reason I waited so long is trust, and that's a big thing. I have met other patients that have had mistakes or things didn't go right, and finally they got the right help, and waiting and insurance problems. And that's something that could be avoided or hopefully streamlined. And that's what AdMeTech is there for, if you catch it early. And it is so important to get tested early and continue the testing. The primary doctors should know more about AdMeTech. And one other thing, with the testing that I did do and all that I went through, what helped me, if nothing else, but mentally, was getting a DNA test. My father had passed from prostate cancer at about age 84. So I always thought it was hereditary. And through the DNA testing, I found it wasn't. But I do have the gene that causes colon cancer. And around December, I got a notice from, I think it was Dana-Farber, that that gene could possibly cause prostate cancer. And DNA testing also helps for alternative treatments. So it's good to do. And it helps my nephew and all know that they got to get tested and what to look for. The good thing about all this is there's a lot of research and things are changing fast. So even if you are sick, if you can hold in there, there's more on the way. that could possibly help. And once again, what I did this past year, I couldn't do back in 2011. It wasn't available. And the idea of research and studies, and you do get a lot of notices for that. Probably scares people too, because we think back to the Tuskegee study. I'm probably going to benefit from one of the studies they're going to do on me, and that is exercise in relation to the hormone therapy, the heart. So I'm looking forward to that in June. It's quite a study, quite a bit of exercise. I'm going to end it there.
Emma Couyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Brett McClay, a patient educator, and other members of the AdMeTech Foundation's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions about our program or need assistance, please contact Emma by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention.
Thank you, Dr. Stern, for that presentation. And I'll turn it over back to you for a Q&A.
Okay. Before we will open to Q&A, I just would like to sort of issue a call to action. AdMeTech has been leading development of accurate diagnostic tools and minimally invasive treatment for over 25 years in prostate cancer. Right now, we're in a position where we can make sure that each man will have access to the best experts available in the state, who many of these experts are also world-leading experts, who have access to the best diagnostics that make it possible for us to determine what clinical care, what therapeutic approach is best for individual men. Would it be wait and see approach for men with prostate cancer that is not aggressive? Would it be minimally invasive treatment that can be administered with minimum complications in ambulatory settings, minimum cost, minimum discomfort to men? Or would it be aggressive treatment to save someone's life? My call to action today is, if you have any questions, whether or not you need to do screening, whether or not prostate cancer screening is right for you, if you're a healthy man, if you were diagnosed with prostate, if you were referred to for biopsy, if somebody told you, if your physician told you that your screening came out in a way that is of concern, if you were referred for biopsy and you're not sure you need that, if you were referred for treatment and you're not sure it is the right treatment for you, please come to us, and we'll make sure that you will get the best care and you will be empowered in making choices that are right for you. I would like to ask actually Emma Couyer to comment. Emma is our manager of the Prostate Cancer Equity Program.
Hello, everyone. Thank you so much for having us tonight. I hope everyone is staying cool tonight. As Dr. Stern mentioned, I'm the manager of the Prostate Cancer Equity Program, and I'm really passionate about this issue because it allows me to talk to men all the time who have a lot of problems when they're at a really serious portion of their life, and I'm able to help them with a lot of the things that are irritating about the healthcare system, whether that be transportation, translation, their health insurance, scheduling, registration, and me and the patient navigators work together to help them through every step of their medical journey. So I'll second Dr. Stern's call to action. Please feel free to reach out to us. I'll be happy to take care of you and work you through every step of the process. So I'll just put my email and the phone number in the chat again. Thank you for having us tonight.
Thank you so much, Emma. Any questions that we can answer? Any questions from people here on Zoom?
If I could, I would like to welcome Dennis Powell, who is an NAACP president from the Western Mass. Good to see his name.
Welcome, Mr. Powell.
You made the presentation to the Berkshire County chapter of the NAACP last year. So I just thought I would get a second round of your presentation this evening.
Thank
when
you
I
so
received the invitation
Great.
from Ken.
Thank
Great.
you for joining us.
Thank
Thank you.
you.
And thank you for your support.
Doctor, I just will say two other things. One other amazing thing is that prostate cancer for many is genetic. And so when I had my diagnosis, I called my older brother and told him, and he went to his doctor, and of course he had prostate cancer too. So I would just really like people to pay close attention should they have a diagnosis, to think of their male family members and to contact them. And last I wanted to say is that the end where my journey is in the moment is they finally did find out where the cancer was, and I'm on a fantastic new pill that I take every day. And all my results are great and I'm great. So I can tell you that paying attention to your prostate cancer diagnosis and following up and working with AdMeTech and getting guided through the system and connected to the various doctors can lead to a very satisfying place. And I'm in that place.
We have actually a question from Bruce. And the question is, can we just ask our primary care doctor to set up a prostate exam? Absolutely. And we really strongly encourage it. If your doctor does not talk to you about prostate cancer, and you're a Black man who reached the age of 40 or above, it is absolutely critical to start discussing a possibility of prostate exam, prostate cancer screening, starting at the age of 40. And actually, particularly for younger men, at the age of 40, 45 in particular, this test done at young age is very important information for us. Before men develop concurrent problems, almost every man at the age of 50 develops, for example, benign enlargement of the prostate, and then blood test assessment becomes more complicated. So if we can get men to do this test early before any other concurrent problems, it's very important for us, because this is going to be absolutely critical in our ability to develop an individualized plan for this man. How frequently, based on his result, how frequently he needs to be tested? Would it be 1 to 2 years? Would it be 2 to 4 years, for example? And is there something that needs to be done right away to save this man's life? So it is absolutely critical to be proactive. And if your doctor does not talk to you about prostate cancer, please talk to him or to her about prostate cancer screening. Aisha?
Yes, thank you. I have a question in regards to the family members who may have, these men in their lives that might be fearful of going to doctors and getting tested and treated, or just getting to know kind of where they're at. What do you suggest in regards to those family members, those women particularly, who are in their lives and trying to push our significant others and family members to get treated and to just get tested to know where they are?
It's a really important question, because as we know, in 70% of American households, the healthcare decisions are driven by women. As women, right now we're talking as a woman rather than a doctor, with your permission, Aisha. When I approach men that I care about, I am very acutely aware that I have to respect their decisions. These are very sensitive individual decisions. And yet it is important for them to tell them that I really care about them. I want them around for a long time. For my husband, I wanted him to watch our son grow up. Now I want him to watch our grandson grow up. We love him, and we want to make sure that he will be okay. And would he mind considering to get tested? And potentially to make sure that he's around and he's healthy. Unfortunately, without prostate cancer screening, there is nothing we can do in medical community. Everything starts with prostate cancer screening. And I think Bruce has one more question. What is the difference between a colonoscopy and a prostate exam? I had a colonoscopy within the past year. Actually, colonoscopy is when gastrointestinal expert is putting a long tube into a gastrointestinal tract. Okay? So the gastrointestinal specialist is looking to prevent colon cancer, is looking for possibility of any kind of abnormality in the colon. When we are doing prostate exam, digital rectal exam, it is also done through rectum. But as Dr. Wason demonstrated graphically, the point of it is to actually feel the prostate. The problem with digital rectal exam, as important as it is for assessment of the prostate, the back of the prostate, we cannot feel the front of the prostate. That's why it is critical to have blood test that basically is looking for any kind of abnormality in any kind of prostate. And then if there is any abnormality, it is really important to consider imaging, magnetic resonance imaging. We actually led development of this technology. Because for Black men, it is particularly important because Black men are more likely to have prostate cancer in the front of their prostate, not in the back of their prostate. So if we do not see it on imaging, we will not be able to reach that part of the prostate, and we will not be able to place needles in the right way to actually diagnose prostate cancer. So it's very important to tell our men in our life how much we care about them, how much we love them, and how much we want to have them around. And prostate cancer strikes 1 in 8 men. It is extremely common, and it is extremely important to have prostate cancer screening and for them to talk to their doctors about prostate cancer screening. Any other questions? Am I clear, Mr. Bruce, about the difference between colonoscopy and prostate exam? Did I address your question? Yes, very good. Any other questions? Great. Thomas, back to you.
All right. And I will close with thanking everybody, thanking President Reeves, and the Cambridge NAACP, thanking Dr. Stern, and thanking our audience not only on Zoom, but on Facebook Live as well. Thank you again for watching this virtual event, and have a good night, everybody.
Thank you, Thomas, for
Have a great evening.
Yes, have a great evening.
Thank you all. Have a good night.
Good night. Thank you, Dr.